Because when I was first studying this, it's like, I don't want to use drugs in my pregnant patients. I'm really scared of the damage it could potentially hurt the fetus. But, insomnia can do a ton of damage to both the fetus and the mother alike.
All right, Logan. Let me jump in. So you said something very interesting before you looked into this issue. You said that you didn't really want to prescribe medications for sleep for your patients, right? And you certainly mentioned the potential danger to the fetus as these medications can cross that placenta barrier. But what other reservations did you have in feeling that sort of way?
Right. I mean, I think I have a certain bias against benzos. I think physicians, nurse practitioners, PAs in our general generation, I imagine, have a similar bias where we've seen the damage of benzodiazepines. And these are the drugs we're going to talk about. Benzodiazepines can be extremely addictive. It's easy to overdose on a benzodiazepine in some regard. So I've heard actually an ED physician say it's not if you can get him into an into a ventilator, pretty quickly. If you don't have your series of benzodiazepines and you abruptly stop, you can get thrown into a seizure. So for a whole multitude of reasons, it's like, yeah, no, I don't want to do that. It's like I can just start feeding into this person's potential addiction issues in the future or just complications in the future. So I acknowledge that I have that bias. Do you think you share that same attitude?
I don't know if I will phrase it as a bias, but maybe we can phrase it as a concern, because what's more common than a psychiatrist hearing about a patient's sleep issue, right? I feel like this is something, regardless of the setting that we're treating patients in, this is an issue that comes up constantly. Doctor, I can't sleep. Can you do something for me?
Right.
And most of the times, you are very, very hesitant to go the route of benzodiazepines. And one of the things that you left out in terms of the long-term harmful consequences is that benzodiazepines is one of the few drugs that you can actually die from if you withdraw from it. Yeah, it's very dangerous, and long-term use can lead to cognitive decline as well. So especially when it's a young patient, as in, patients that are of childbearing age, I'm even more hesitant. But to be honest, it's not so, given the levels of danger, it's not a medication I feel very comfortable prescribing.
Mm-hmm.
And, besides the inherent dangers of that medication, I also question how much is a benzodiazepine really doing for that patient? So,
Right.
For example, they've done sleep studies on this. They've looked at patients, placebo versus putting patients on a hypnotic sedative, right? These benzodiazepines, the Z drugs, they're considered sedative hypnotics, right? Because what does it actually do? In your brain, it's hitting the same receptors that alcohol is essentially hitting. So it's basically alcohol in a pill form. And what happens when you drink too much alcohol? You start to get a little bit woozy, and you can pass out, go to sleep, right? So there's a clear distinction when you look at sleep studies that show that real sleep and benzodiazepine-induced sleep, there's a difference in the brain waves that are measured. So for example, when you look at patients that fall asleep after taking sleep medication, they're missing the deep delta waves on the sleep studies. And that's stage, N3 and 4. We can get into the details of sleep.
Right.
But, long story short, those are the most important components of sleep for you to get a full night of restorative sleep. But at the same time, when you ask these participants, they can't differentiate between the real quality restorative sleep of naturally induced sleep and then comparing that to the benzodiazepine induced sleep. So people mistakenly believe that they're getting restful sleep, but at the same time, when you look at the sleep studies, the quality of the sleep is vastly different. And that's why when patients take these medications, a lot of the times they'll come to us and they'll say, hey doc, I feel super groggy in the morning. I still feel a little bit woozy, right? And then what happens in that circumstance? They'll usually reach for an extra cup of coffee.
Right.
They'll be more tired in the afternoon.
Let's hope it's coffee.
Yeah. Or whatever else they're using,
right?
They're going to reach for a stimulus, something to give them a kickstart. And in turn, that night, because of the residual effects of the caffeine or whatever substance that they're taking, they have even more of a trouble falling asleep. And what do? They take more drugs to help fall asleep. And it becomes this perpetual cycle that leads to a downward spiral.
Right.
That's my concern, my biggest concern.
I think that was, beautifully said. And, actually, I'd really like to, in future episodes, get into the nitty gritty of sleep, getting into the different sort of electro waves that we can measure with sleep. Why I think I used the word bias earlier is I've seen, I don't need to say the number, but more than enough of pregnant mothers who come in addicted to many different substances. Their fetus is exposed to many different those substances, and at least about outcomes. It's tough to see. It's cases like that I find most challenging in this career, regardless of if it's in the mental health industry, right? Anyone who's in the healthcare industry touches these cases in some regard. These are the cases that I feel like that keep you up at night, that you think about when you're talking to your wife at dinner or when you're even playing video games, a time where your mind should be clear. I think that's some of the most challenging aspects of this career that we've chosen working in healthcare is those tough cases where you have that mother that is dealing with some substance use issues. Maybe they don't want to necessarily harm themselves or the fetus, but they're not able to stop that substance use. So that's my bias towards even using a lot of these medicines, because I don't want to feed into this at all. I want to try to teach these patients, to the best of my ability, of course, to use. We're going to even talk a little bit about cognitive behavioral therapy for insomnia, other healthy modalities. A lot of this conversation today is going to focus around the drugs, whether to use or not use it. But, as much as we can, try to encourage these patients to use non-pharmacological methods to try to improve their sleep.